I can't. Okay, do you want to get started?
Yeah.
Okay.
So we can get through some of the overview stuff.
I guess we'll go ahead and get started. Thank you all for showing up on Friday at 12 o'clock. We really appreciate it. I know this is not the, this is one of the, tougher times to make, so we appreciate it. We'll just go ahead with some quick introductions. I'm Amy Seiden. I'm a emergency medicine physician at Emory. I work at Grady Hospital, which is a county hospital in Atlanta. And for many years have been the co-director of a medical legal partnership focused on asylum and immigration, really outside of the hospital. So we do forensic evaluations for asylum seekers. And recently we started a medical legal partnership in the hospital in the emergency department. So it's very nice to be able to figure out how we can actually implement legal interventions in the emergency department. And I'll say much of what I've learned from Dennis. So I'm very happy to have him here, who's the OG and really started this within our field. On to you.
Sure. I'm Blake. I'm a PGY2 at Harvard, the MGB site, and then also a fellow at Yale Law School, where we have a slate of 8 MLPs, none of which are in the ED setting, so very interested in both starting one there and at MGB, but excited to learn from both of our friends.
Great, and I'm Dennis Shia. I'm currently Chief Medical Officer at Central California Alliance for Health, which is a Medicaid single-payer plan for 5 counties in California, from Santa Cruz and Monterey out to Yosemite. And at this stage, I'm trying to pay people to do medical legal partnerships and address social determinants of health in the emergency department. So I've got not enough people who want to do this type of work. So if you're looking for a job, I've got lots of emergency departments that are hiring in my service area. Santa Cruz, Monterey, Yosemite, all over. So we're happy to talk afterwards.
But if you're independently wealthy and you want to pay for a medical legal partnership, I would love for you to come to Atlanta to support ours. Okay, we have no disclosures. Just a quick, you're doing I'm doing the background, yeah, I'm doing the background. Okay, has anybody heard of a medical legal partnership in a hospital setting? So there's actually over 400 medical legal partnerships in the United States, but many of them are actually with outpatient settings. It really started a lot with the HIV clinics, with the Ryan White Act, and some pediatric clinics. There are some in pediatric hospitals, and some are hospital-based, but very few, probably, I think the only ED-based medical legal partnerships are the ones that Dennis started and runs in California. So the goal is that you have a lawyer, a civil attorney, in the emergency department who can help your patients with health-harming legal needs. And we'll talk a little bit about what those are. So this is a little bit small, but I'll kind of talk through it. So if you look here, you can kind of see the overlap between social determinants of health, health-harming legal needs, and social needs. And the point, I think, is that the idea is that the legal team is part of the spectrum of care and social resources you provide to patients. So they work closely with you, they work closely with your social work team, they work closely with your case managers, but they address needs that may seem social in nature, but are actually hidden legal needs. So a good example of that is, I would say a good one is housing. So sometimes people come to you because they need shelter, and social work can help with shelter resources. But some people may need help with eviction or housing accommodations, or accommodations because they were injured and they can't get up their stairs anymore, and they're on public housing, they're on a voucher. And so that's where the lawyer really comes into play, where that need is distinguished from social work, and a social worker would not be able to help with that need. So that's kind of how the team works together. And I think the nice thing is that there is so much overlap. So if you look at social determinants of health, how they overlap with legal needs and how they overlap with social needs, you'll see that they kind of all mingle together. So if you can address one, you may be able to address the social determinant of health that is actually bringing that patient to the emergency department. We'll go through this in a little bit more detail, but just to kind of highlight what are health-harming legal needs, they fall under income and insurance, housing and utilities, education, employment, legal status, and personal and family stability. I have a good slide later on that kind of shows you what all those things are, but it follows the iHealth framework. So ideally, a patient comes to the emergency department, they get screened for social needs and health-harming legal needs, and you provide them with a social worker and a lawyer who can help them with those. And one important thing I'll say about health harming legal needs is just like social needs, many people have more than one. I would say most people that we have helped with our medical legal partnership come in with eviction as a need, but when you actually screen them with the legal intake, they'll have many needs that you recognize. So this is just kind of another way to look at it from the perspective of how does a legal intervention address social determinants of health. The legal needs that are listed here, the health harming legal needs, all fall under the social determinants of health categories. So again, the goal is really that if you solve or help the legal need, you're addressing the underlying social determinant of health. Okay, go for it.
So one of the things we wanted to do is walk through, if you were designing a medical legal partnership in your emergency department, how you might go about doing that, some of the changes or the options that you would have. So just the general flow of a medical legal partnership is screening and identifying the precise legal needs and health harming legal needs of your patients. And so a good place to start is either a needs assessment or screening questions, figuring out your staff, et cetera, which we can talk about a little bit later. The next is connecting those patients with legal services. A number of different ways that can happen, options for lawyers that you can choose either in-house or out-of-house, and then follow-up to make sure that the hospital itself is actually following those patients and the interventions that they're getting connected with. So just to talk about the evidence a little bit, as Amy mentioned, there's over 400 national MLPs. Vast majority are in outpatient clinical settings. They help a large number of patients every year, 75,000 roughly. And a big component of what they do is also train clinicians and associated staff to identify these issues and give them knowledge of the resources in the surrounding community. So these are just there's data for all of these, but some of the benefits that folks have seen. There's more frequent reimbursement for clinical services that could be through connection to Medicaid, Medicare. Again, recovery of social services benefits, improved compliance for medications, and reduced admissions for chronic illness, especially in pediatric populations. To that point, Cincinnati Children's has a very large, long-standing medical legal partnership that's now helped over 19,000 children, recovered over 1.3 million in public benefits, and a 38% decrease in hospitalization. A lot of that has to do with housing, identifying people at risk of things like asthma from mold, evictions, things like that. So these are kind of the considerations walking through a medical legal partnership. The first is defining your scope, the issues that you're capable and want to deal with. Second is screening for those issues, staffing your partnership, funding it, and then choosing your metrics.
So I kind of mentioned some of these, but I think it's just helpful because when I was starting to look into this, I was like, I don't know what a civil attorney does. I don't know what health harming legal needs are. I don't know kind of how to separate that. And I fortunately have an amazing lawyer who works with us through Atlanta Legal Aid Society. And the I think really helpful thing is that every state has a legal aid society that's funded typically by Congress. Correct me if I'm wrong. So that in your state, there is likely a legal aid society that already serves a patient population that's likely to seek care in the emergency department. They have certain requirements of the socioeconomic status of patients that they serve. And so they likely already know the needs of those patients and help them anyway. But in this case, you're just bringing them to the emergency department. So what I have learned is, and some of the big ones I think are what they can help with are public benefits, but it's really the appeals. So we have a lot of people that get denied SNAP for the stupidest reasons, but there's nowhere to appeal. So they just kind of accept, like I got denied SNAP. And so our attorney will help with those appeals. It's the same thing for WIC, for SSI, SSDI. Go ahead.
So I think one thing to think about, because I think it's being a lawyer, you're like, oh, that's a legal issue, and then not being a lawyer, like, what's a legal issue? So how I think about it is there's stuff where you have conflict with people or you don't have conflict, right? Like if I haven't applied for SNAP, there's no conflict, I just need to go apply for SNAP. But then if someone has denied me SNAP, now I have conflict with someone. I feel I applied, I want it, someone's telling me no, there's a conflict. That's where a lawyer can come in. So if you take that and apply it to any of the things you see with your patients, if you can identify some sort of conflict, there's probably room for a lawyer.
And I think it will make it should ideally make your hospital happy, right? Because you're offering a service that they really cannot do. If somebody gets denied SNAP, that's not something that a social worker could necessarily assist with. Housing is a big one. So eviction, living conditions bring people to the emergency department all the time. This has been very well studied in asthma and COPD, that if you have poor housing conditions, mold, pests, et cetera, that you are more likely to have more exacerbations of your respiratory illness because of your living condition. And so the lawyer, having just a letter sometimes from the lawyer to your landlord that says, you got to fix this, they magically fix it. And then another thing that they can help with is accommodations, which we have seen a lot. So for example, someone got shot near their house, didn't really want to live in their house again, understandably so. And so they were able to get them accommodations with their public housing to get them moved to a different house and paid for their moving expenses. So there's more kind of under this housing category, but I think these are kind of the big ones: housing and eviction. Employment, so labor law, working conditions, employment discrimination, wage withholding, disability law, veterans law, immigration, and other forms of legal status. The note I will make about that is our legal team refers out because immigration in Georgia is really complicated, and so you really need an immigration attorney to help with that. But if your civil attorney doesn't do it, they often can refer out and they know who can help with it. And then family law is a big one. So helping with custody, guardianship. We had a case recently where a woman was injured by her ex-partner, but has kids with the ex-partner. And so if something were to happen to her, her money would go to the father of her children, who was the perpetrator. And so she was able to work on guardianship issues, both for that and for her children, to make sure that they weren't in an unsafe situation. And then a lot of it, like estate planning, helping with power of attorney, so on and so forth, especially for those really complicated cases, which we have a lot of in our hospital. So they can really help sort through that as well. The only thing I would say, and Dennis, please correct me if I'm wrong, but typically legal aid societies cannot help with criminal cases. They can help somebody who has criminal involvement or justice involvement, but they cannot help with criminal cases, and that's not necessarily within their scope anyway. So if that's something that is important to your hospital system, which it is for us, we have talked about unique ways to think about that, where we would essentially have a medical legal partnership unaffiliated with Atlanta Legal Aid Society, but working together. And then what I'll say too is kind of how we started this is the National Center for Medical Legal Partnership does amazing work. So if you go to their website, they have a toolkit and they can kind of help you say, like, here's step one, here's how you find a legal partner, here's how you do a needs assessment. So we started with a survey of about 200 patients in the emergency department to understand their health harming legal needs. And not surprisingly, over 80% identified a health harming legal need, the most being income, insurance, and then housing was the next big category. So it's, I think, really helpful to sort of do that needs assessment so you can really understand what kind of lawyer, what kind of legal team do we need? What issues are we seeing? Especially if you don't have access to a full-time lawyer or you're piloting it, you can start with specific legal needs and say, all right, we're gonna help with housing and income because these are our biggest needs that people have. But conversely, too, you can also develop educational tools around that for patients and for staff. So it doesn't even necessarily need to be the lawyer that does that, but it can be your team eventually in like a dream world that can educate patients and educate patients in a community setting, too, about, you know, here's what we're seeing related to these most common needs. Okay. Go for it.
So after you've defined your scope and your health harming legal needs targets, the next thing to do is screen patients in your ED for that. There aren't a lot, but the ED medical legal partnerships that exist often use either volunteers or an in-house attorney that's doing the screening. But other options are having social workers participate, having patient care navigators, and then have a documentation system for that screening in the system. I think with Medicare reimbursement, Medicaid reimbursement, we may be moving towards actually being able to bill for screening like this and then intervening for it more easily than currently exists, so documentation is certainly important. And then transferring screening to the outside organizations if you're using them. So this is one example. This is from Cincinnati's MLP in the pediatric population. A lot of different ways that you can do this, but the goal, I think, is to make it both quick, broad enough to get a large catchment, and understandable for folks in non-English speaking patients and other populations. The next thing is choosing your attorneys, and this can be really tricky. Like you mentioned, legal aid societies both have incredible funding constraints, and they also have constraints on what they can actually represent folks for. And so they're a very robust and available option in most places, but you have to work with them to figure out what exactly they have the capacity to do and the expertise to do. Law firms are also helpful for this. So I've worked with law firms in veterans legal services and pro bono cases primarily. Others are city and state programs. And then I think one of the best options is to have an in-house staff, either fellowship funded or funded by the actual hospital, to sort of entrench that infrastructure. Mount Sinai has an equal justice fellowship where one of my law school colleagues was there for a year, and they work very closely both with the general counsel's office and with legal aid partners. Second, and we talked about this a little bit, is funding. 50% of all MLPs have a contribution from the health system that they work in. Some hospital systems are very excited about doing this, either through community benefits requirements or through Medicaid funds. Massachusetts, I think, is a good state for us to do that in. And there's HRSA grants, targeted state federal grants. Massachusetts has a fair amount of money in the veteran-specific population right now that they're looking at building into the medical system. A second category is legal funding. So 25% of MLPs have Legal Services Corporation funding, which is also federal. 64% though rely on private philanthropy. So you need lots of engagement from your surrounding community. Metrics and outcomes are one of the trickiest things to do. I think a lot of programs in the hospital that target social needs have failed because of how they define their metrics and just the naturally short funding timelines that a lot of folks are working under. So some of the ways that they break this out are in learner outcomes, which are potentially more quantifiable, more studyable, and a little bit more familiar for academic healthcare systems. So this would be the number of folks that you're training in legal needs, folks' familiarity ex ante and ex post, and patient community health outcomes. That can be tricky. Obviously, intervening on a legal issue is an attenuated process from that intervention to a health outcome. And so you need a longer timeline or a health system that has a lot of tolerance for that. And then the third layer is health system savings. And so if there's a way to define the savings in a shorter term, like connecting folks with Medicaid and saving the hospital direct insurance reimbursement, that is potentially a better option.
So I'm going to talk just a little bit about our pilot program, but before I dive into that, I will say we started talking about this in 2020, and the biggest challenge for us is that our general legal counsel was wildly opposed to this. And for reasons I understand, but that are quite silly. And really, it's just because they're risk averse. So I think it really depends on your general legal counsel, because that's who you need approval from if you're going to have a lawyer that's unaffiliated with them in your hospital. And so our general legal counsel was very concerned that our lawyer would see things in the hospital that are problematic or pick up med mal cases. And there are plenty of problematic things at our hospital. And so that was their big hesitation. But we have essentially a memorandum of understanding with them that says Atlanta Legal Aid will never take an adverse position to you. So they can't take on cases if you're unhappy with your care at Grady. That's not an issue that the lawyer can help with. So they really focus on those civil needs. So I think it's really important as like kind of a first step of this is obviously doing a needs assessment, understanding what your needs are, finding your partner, but then trying to figure out who in the health system is going to sabotage you. And for us, it was general legal counsel, but we're now friends, sort of. And I should say that the first MLP in Atlanta started at our children's hospital about 15 years ago. So we really had a framework already with Atlanta Legal Aid, and they approached our general legal counsel at that time, and he said no. So it took many years, and it really took a champion. So I would email him probably every single month and just say, would love to talk about this again. But it also helped having our medical director, who the general legal counsel really likes, also support this. And so I think you kind of have to find your champions and supporters who can help you talk through these barriers to really overcome the hurdle. So I will say the pilot did not start the way I wanted it to, but we got a yes. And so we had to start small. So that was kind of our biggest challenge, was like even getting this into the hospital. And we work very closely with general legal counsel to say, like, is it okay to do this? Is it okay to do this? Currently, he's not okay with our lawyer going to patient's bedside, which is very challenging because that's the whole goal. But what we had learned from COVID is that a lot of these things can be done virtually. So our lawyer, who ran 2 medical legal partnerships before this, she said, actually, when COVID happened, I was surprised at how engaged people were, even over the phone after their visit, if you give them a referral. So what we started with is a pilot where it's not yet in the emergency department, but we serve ED-adjacent programming. So we serve our trauma recovery center, and we serve our hospital-based violence intervention program. The benefit of that is there's kind of a middle person that almost does the screening, because that middle person, the therapist at the TRC, the VI, the violence intervention specialist at our HVIP, they get to know the patients really well. And so they kind of understand their need when they first interact with them, and then they can refer to us. And then our lawyer will follow up with them. And our lawyer, for the most part, has done all follow-ups over phone, or will go to our HVIP clinic and meet with clients and go through some paperwork with them if need be. So it's like I said, it's my dream is we have 5 lawyers in the hospital, one at least, probably 2 in our emergency department, another serving ED adjacent programs, another in our trauma center. But for now, we have 1. And the other problem is we only have funding for 25% of a lawyer. Our funding came through the state judicial branch, and how that worked is your legal aid societies are already probably lobbying in your state, and so they can potentially get more money in different ways that we may not have access to or know about. So our state judicial branch, they lobbied, and essentially the state judicial branch said, we will give you X amount of money for the next year to fund medical legal partnerships. So it was another reason why we started with a small pilot, because we only had essentially a less than part-time lawyer who is doing probably part-time work, but getting paid less, just like probably all of us are doing. So our pilot has been really successful. I would say we get about 20 referrals every quarter. I'm not going to go through all of these, but I've kind of talked to you about some of them so far. I would say housing and eviction has been a really big one. Here you can see like 1 person avoided foreclosure, another person had a reasonable accommodation, 2 patients avoided eviction. And what I'll say too is when you get an eviction, evictions, I'm definitely not as aware of the eviction process as probably Blake or Dennis. But you will get a notice, but then when you actually get that notification, like you have to leave your house, you have to leave your house within 7 days, and you have to appear in court within that time period, at least in Georgia. Our lawyer will actually go to that eviction hearing if notified more than a day in advance. And so, again, they do really amazing work and are willing to go to, in a lot of cases, willing to actually go to court with the patient to help them. Okay. Let me see if there's anything else that I think would be, I would say the last one on here was a big one. We had a person referred because they weren't getting their victims of crime funding, their compensation, because the argument was that they had already applied for disability. But disability takes a long time. So our lawyer essentially argued and said this person should still have access to the victim's compensation because it will happen before their disability claim is even reviewed. And so that person got $10,000 and was still able to then apply for disability. I'm probably saying all these legal things wrong, but Dennis hasn't corrected me yet. So I talked a little bit about kind of the challenges, I would say mostly with our general legal counsel and with funding. Other strategies that we've thought about for funding is we went to our hospital's foundation, the Grady Foundation, to see if they could help us with ideas or private funders. Because oftentimes if you will get it started, people won't necessarily let it die if you can just kind of get your foot in the door. And our legal team, our legal aid society has actually, for our children's team, has funded, if they say if the hospital meets us, like, if the hospital gives us 50%, we'll give you the other 50%. So they have matched at our children's hospital, even though they don't have a lot of money, but they're still willing to support it. So I think sometimes it's more of a piecemeal and like getting the money where you can and thinking about long-term sustainability. And I would say that long-term sustainability is how do you operationalize it so that your hospital pays for it. Given the revenue that the medical legal partnership can generate or save for the hospital and the benefits to patients that then actually reduce their healthcare utilization, this is a wise investment for hospitals. You just have to figure out how to sell it to them. So one thing we're looking at is Medicaid denials. How many patients can we help with Medicaid denials? Because in Georgia, we don't have Medicaid expansion. So it's hard to say, we're gonna get all of these patients who haven't had Medicaid on Medicaid or Medicare. But we can go to our financial department and say, how can we connect with people who have been denied Medicaid so that our lawyer can help with Medicaid denials and then show revenue, generated or saved, essentially the lost revenue that they would have from uncompensated visits to then pay for the program. And that's how the program pays for itself. So I think that's a really important strategy of thinking about how can we make this financially beneficial for the hospital so they'll at least pay for it. Go ahead.
Is this something that you're tracking in your metrics of how much cost for the system has been, saved thus far, or in the future? Are people researching this? Because it does feel like that would be, a major thrust for the hospitals to be able to say, look at the data, look at how much we've saved.
Yeah.
This person,
Do you want to talk
this different trajectory?
What has been studied in the literature is often that lost revenue, the number of people that got onto insurance and then their visits were paid for retroactively. So we worked with our financial director at Grady and said, can you just let us know after we get these people enrolled in Medicaid, can we just work with you so that we know, did it go through? Are you seeing it from your end? Was it approved? And how many visits did it cover retroactively? And then you can kind of proactively do it. There has been some stuff in the literature too looking more at healthcare utilization. And for the most part, healthcare utilization for the ED and hospitalization goes down. But my hypothesis is that probably outpatient visits go up, which I don't know that has been studied in that great of detail. So the goal for us is in a funded study that we hope to get in the future, every hospital system has a billing system that they use. So you can actually go back and say, all right, pre-intervention, post-intervention, what was the healthcare utilization? So every imaging study, 1-day hospitalization, 2-day hospitalization, has a amount in that system that your health system uses to charge a patient. So our goal is then to go back and say, can add up the visit summary, the cost of that summary, and look pre-post to see how healthcare utilization changed, but also what was that cost savings to the health system. Do you have more you want to add? I feel
Yes,
like
I think healthcare utilization is one way to look at it. I mean, I think the other way to look at it is like, who's ultimately paying the bill,
Yeah.
right? That's usually their insurance company. And so I think that's an underutilized resource, right? And this is why in California, where I am, there's a whole movement, our whole Medicaid waiver is around in lieu of services, which is basically a fancy way of saying, we'll let you do other things instead of paying for ED visits and hospitalizations with Medicaid dollars, as long as you don't spend more and you possibly spend less, right? So that's why as a Medicaid payer now, we're like, okay, we will pay for things like this because like a legal services attorney makes as much as a resident does.
Sad.
So
It doesn't cost that much money.
It's relatively speaking, like 30 to 50K. It's not a lot. Like a couple like one ICU stay cost me as an insurer much more than that. So like the math is real easy, even if it's like 3 people I keep out of the hospital. Everything else on top of that is just like the ROI just goes through the roof from an insurance company's perspective, right? And that's just talking about like acute care utilization, not so much talking about like if they adhere to their meds, so I don't have to sort of do amputations or other stuff. So there's sort of, I think, short and long-term things.
Mm-hmm.
Obviously, I think the ED and inpatient stays are like the easiest ones to impact and also the biggest dollars. So those are like the easiest ones to study. But I think there's sort of longer-term population health effects as well.
Okay, go for it. You want to talk about your pilot a little bit? Yeah, I would say that was the one thing that was shocking to me when I worked with our lawyer. She said, Amy, I don't get paid that much. So like, you really don't have to allocate that much funding to support a lawyer. So we, in funding applications, we allocate $150,000 for a lawyer. So if you think about what that cost is for a year, if you think about what that cost is to the health system, that's like nothing. The other thing you can do is you can be creative. So you can have a paralegal who maybe does screening and then refers cases to the lawyer so that your lawyer time is less, but your paralegal time is more. And I think, you'll talk about it in your pilot too.
Yeah. So I'm going to talk about my pilot, which is from a few years ago at Highland, Alameda County in Oakland. And so this was some work I did as a resident. And, similar to exactly what Amy was saying, right, is we sort of had a layered model because we know social workers have always been scarce and unfortunately continue to be scarce. So we really wanted to bring in sort of people who can help with things that social workers said they didn't have time for, like helping someone fill out a food stamp application, for example. And also lawyers to sort of troubleshoot and help with those more complicated issues you've heard described. So we sort of had this 3-tiered model. And in terms of how it worked was really, we had a help desk with volunteers, retirees, college students, pre-med, pre-law, pre-social work, pre-public health, really doing screening in our ED lobby and also in our outpatient clinics. And they would then, if people needed certain things, we had these algorithms that we put together where, sure, if someone screens positive for food insecurity, are they eligible for food stamps? If so, help them apply, right? Sort of a step-by-step of ways that someone without a lot of professional training can help someone get started in the system. And obviously at some point, as Amy described, you'll hit something like, oh, they got denied for their food stamps. They would like to challenge that. Then you could refer to a lawyer. So it was sort of a tiered model, and then with the social workers serving as sort of champions and supervisors for the volunteers. And then, in terms of lawyers, similar to everything that was described, we sort of scrapped it together. We had one organization that was interested in doing this just because they thought it was a good idea. And then we had a couple other organizations who had legal fellows that was described earlier. And those are like 1 to 2 year fellowships that national nonprofits or law schools or other things will fund to do something interesting and get lawyers started off as like doing public service. So we snagged a couple of those and sort of cobbled together this sort of multi-agency partnership where we had some people specializing in immigration, some people specializing in benefits. And even if they weren't there that day, people knew how to refer to them and they could pick up cases. And, sort of, I think one of the big outcomes from this was just looking at what providers thought patients needed versus what patients thought they needed. So you can see in terms of what providers were focused on were the red bars. So it's mostly stuff like we surveyed ED docs, PAs, NPs, and you can see it was mostly they felt people were coming to the emergency department because they couldn't get access to a specialist, they couldn't get access to their primary care doctor, right? A lot of the traditional things, but the one area where there was overlap was housing, right, which is the very bottom. And then you can see the blue is sort of arranged as from the patient perspective in terms of what patients found most interesting or most concerning to them. And even though they were in the ED, housing, food, job, money were like the top ones. Like pretty much the only thing that overlapped with what providers thought patients were coming in for was housing. And then, we sort of did a little work at looking at with our model, sort of a hybrid help desk, medical legal partnership model. Did this help with any outcomes? And the outcomes weren't super robust, but they did show some increased awareness of resources, increased contact with resources, and then increased sort of follow-up with primary care docs. And then I think and then at 6 months, we sort of looked at some of the utilization and other things. A lot of this was not statistically significant, but it was interesting that patients did overall seem to have a better understanding of how to access the healthcare system as one of the byproducts. So this is really early work. That's pretty old at this point, but I think sort of, once again, goes to the argument, depends on who you're selling this to, right? I think insurance companies probably care more about that, like using the medical home thing than anything else, right? Whereas if you're talking to other funders or other people who they may be more interested, like, did you get pregnant women connected to WIC or something like that? So it really depends, I think, crafting your narrative on who you're selling to.
Awesome. And I do not have involvement with anywhere that has an ED-based medical legal partnership, but just for the purposes of questions later. Yale has them embedded both in the cancer center, a primary care clinic, and sort of the larger, more entrenched homes for patients. And I think one of the challenges with an ED-based medical legal partnership is that they can't follow up in the emergency department. So I think one of the most effective things that you can do is find the places that are seeing a high volume of lower income uninsured patients, vulnerable populations, and doing the screening work and the intake work in the emergency department, get the people who are falling through the cracks, and then bringing them to existing infrastructure. The other thing that we haven't talked about that I think medical legal partnerships can really help with is legal assistance, legal information that doesn't require a lawyer. So doing things like templated legal advice for like eviction letters and things like that, and instructions for patients that you could put in a discharge pamphlet or something like that. But for the sake of time, should open it up for questions and then have some. Yeah.
I'm curious how much involvement in things like relief from abuse orders or guardianship
Yeah.
work, how has that been?
A lot. Yeah, I would say when we did our screening, it wasn't a large percentage, but now that we're getting referrals from the Trauma Recovery Center, a lot of them have been for protective orders. And protective orders, what I've learned, again, I didn't know a lot of this stuff beforehand, is that they're not that hard to do, but sometimes having that lawyer facilitate it, because the rest of our staff is just so stretched that they can't do it. So our lawyer always says, like, we probably don't need a lawyer to do this, but I'm happy to do it. A paralegal could do it as well. What's interesting is that a lot of our patients have not wanted to pursue a protective order for a variety of reasons, which I understand, but they still go through the legal intake. So when our lawyer, whenever we refer patients, they have a standard legal intake they go through. And so they may not want a protective order, but they may need help with food stamp denial. They may discover other legal needs. So I would say everyone who's been referred because of a protective order has not taken us up on that support, but has gotten help with another legal need. They do a lot of guardianship, divorce, custody. Our children's hospital medical legal partnership does a lot of that as well. And really what's nice is that the requirement to be seen by a lawyer is actually quite loose, and you can make it quite loose. So at the Children's Hospital, you just have had to have been at that hospital at one point in time. And that's the goal for our emergency departments. If you've ever been in Grady, if you've run into the hospital, that you would be eligible for a referral. But again, ideally, the lawyer is in the emergency department so they can come to the bedside at the point of care when that person is there.
Yeah, on the guardianship conservatorship spectrum, we have, at the one I did at Harvard UCLA, we had it serving the entire hospital, including the emergency department, but also on the outpatient side for our Jerry clinic. And so they had a lot of things. That was one of the top issues in the Jerry clinic, was really advanced directives and sort of conservatorship and power of attorney, things along those lines. So definitely, I think they can help with all of that. It just depends on, sort of who's referring and how it's scoped.
There's a lot of funding in cancer centers for this. So the Yale Palliative Care Medical Legal Partnership is based out of Smile Cancer Center and does wills, trusts, power of attorney.
I think too, a big component of medical partnerships can be education. So if you kind of look at the breakdown, if you have one lawyer, what they recommend is one lawyer will help 100 patients each year. Not 100 cases, but 100 patients, because a patient may have multiple cases. But they can also do a lot of their time with education. And so some of that may be, like what I've tried to do is, now that I know the legal aid resources, I know that if you call it legal aid and you say, I have cancer, they have a dedicated program for you. If you call legal aid and you say, I have, they have a kinship program, so if you're taking care of a child who's not yours, for example, they have a program for you. So again, it's like, you kind of then start to learn what the legal resources are, so that even if your lawyer cannot help, or you don't yet have a lawyer, or you don't have a full-time lawyer, you can figure out how strategies to support your patients.
And I think one other way to implement this is just thinking about it. I think sometimes people think of medical legal partnerships as standalones. And I think how we're looking at it more and more in California is there's a lot of payments for like enhanced care management, which is like complex case management for patients. And, sort of someone has to do the math, but you could think not everything, sort of what I showed earlier, right? You have different levels of care. You could have community health workers working with licensed case managers, social workers, or RNs, with part of a lawyer to support a whole team, because it sort of funnels up to a lawyer of what you need, and not everything from a lawyer requires going to trial. A lot of it could just be a phone call and could be relatively quick. So I think thinking about it, depending on what your landscape looks like, think about it as an integrated model, and fitting it into your existing structure is also sort of, I think, an interesting way to go.
Yeah, I was just going to ask about the timing of the assessment, and you mentioned, your general counsel not wanting them at bedside, and I know with any kind of social emergency medicine initiative, it's like one of the primary concerns is slowing down throughput, and it feels like, trying to provide any of this assessment or the follow-up or any of it bedside could really slow down throughput. So what have you all found as models for, are you just trying to reach these people by phone after they've been discharged? I mean, because I know a lot of our highest needs patients, their phone number is listed as 11101.
Yes.
So then, how do we follow up?
I would say our goal is, the goal is that the lawyer would come to the bedside and say, I can help you with X, Y, and Z at discharge. And then there would ideally be just kind of like our social workers have an office right outside of the emergency department. There would be a place for them 9 to 5, or hopefully like some evening times as well, where we could send patients directly, and or we could make an appointment for them. So if you come at 11 o'clock at night, we can make an appointment. We know the lawyer's going to be here from 9 to 11 tomorrow, so you can go to their office tomorrow, come anytime, and see them. That's kind of the goal. I would say with that's especially for patients who don't have a phone, don't have transportation. Our hospital is very much like you show up and you can get a lot of services done. That's kind of the goal, because we recognize a lot of those barriers. And so we would fit it into that model of availability. But so far we have had good success with people who have phone number, with follow-up calls. But I would say one thing our lawyer, I think, thinks is really helpful is that face-to-face. Because when you stand and refer you to a lawyer, you're like, I don't want to talk to a lawyer. Like, lawyers freak people out. I know they freak us out, but they, it's kind of intimidating for patients. So sometimes just meeting that person in real time, if possible, can be really helpful to establish a relationship and won't slow things down if you're just sending them, for example, to their office after they get discharged.
But even just that point of identifying them for the referral to say, we've got 10 patients roomed, patient in room 3, I think I want you to pop in and do a quick stop with them. Like, what's the assessment tool to sort of determine that?
I think there's a lot of different ways. The problem is not a problem, but if you screen for it, you have to provide the service. So in some respects, that's kind of the challenge with social needs screening as well.
Yeah.
And so ideally, we would screen for it if we had a full-time lawyer and then offer it to patients where if there's like multiple dream models, right? Like it could come up positive where if you screen positive for it and it's in EPIC, then that automatically goes to our lawyer and they can follow up with the patient. But that's tough because you're gonna get a lot of, you need essentially like a paralegal or somebody to kind of sort through that. Another kind of abbreviated model is you as providers or as clinicians are trained, and your social work team, your case management team, are kind of trained on how to recognize it, and then when the need arises, then you call the lawyer to then come help. The other thought we have is having a lawyer around with us, but generally the council was like, absolutely. But it's really just trying to integrate them as much as possible, so that patients see them, your clinicians see them, and know that the resource is there.
Yeah, I think for us, I've seen a couple different models. So at Highland, we literally had the advocates just in the waiting room. And unfortunately, there's time. So a lot of the capture was not like the code 3 that came in that needed to be 2, but it was all the patients who were coming in through the front door and capture that way. And then at Harbor, we've piloted a number of iPad-based screeners, either with a chatbot, like sort of with voice and audio for people who aren't necessarily able to interact with a visual perspective, whether it be literacy or something else, and use that to sort of then drive identification. I think when I left Harbor a few years ago, we were in the process of sort of looking through putting kiosks in the waiting room where people can go up, go through the screener, have that pop, then eventually pop into the medical record, and then both a resource sheet, which is not ideal, but it's a starting point, and then also live referrals. So there's, I think, a number of ways you can operationalize that you can take advantage of. It's not 100% capture, but it's a good starting point, and then you can sort of PDSA and optimize off of that to try to increase your capture.
I think to your point about ethically needing to be able to offer the services that you're screening for, one of the things that we've been thinking about doing is an iPad app as well, where you could even have somebody in the registration process just be handed a list of health harming legal needs. Like, would you like to talk to somebody about billing? If so, talk to a member of your care team, or obviously a QR code in this population is a little tough. But having multiple touch points through both the waiting room and when they're getting screened by registration, or just throughout the stay, having the ability to reach out to a member of the team. And then once you identify a certain need, at the very minimum, having auto-population in the discharge paperwork of local legal needs and social needs.
I mean, even just looking at when we did the screening, it didn't slow throughput down. We had a dedicated team that would screen patients, would actually read the screening tool to the patient while it was essentially after they were roomed, not even in the waiting room, and it didn't slow things down. But I can see how when you actually bring the intervention to the bedside, that would potentially slow things down. But it's just like how when we refer to social work, we discharge patients and then we send them to our social worker, unless it's unless it's a sensitive situation. So I think, it depends on your institution. It will have to could be potentially a combination of things and a lot of trial and error. One thought too we had for piloting was just starting with our social worker and case management teams, so that they get the kind of the complex cases. And I also think they would appreciate that a lot, but it does take a lot of education to the people who will be referring, for clinicians, for social workers, case managers, whoever will end up doing it.
Yeah, I've heard a lot of fear of this sort of like, you can't unknow what you are told. And so even when we look at efficiencies of like iPad systems, or like, let's send out a MyChart message that gives them this screener while they're in the waiting room. There's just a lot of immediate pushback of like, no way, because the volume that could come in, and if somebody is now reported domestic assault or something that then somehow isn't picked up within a quick enough amount of time, responded to, that came in this kind of electronic format, and we act on, there's all this liability and risk here. And sort of like, if we don't know it, there's no liability, but once we know it, if we don't respond to it and act on it, and we don't have the resources to act on it, so we're just gonna not know it.
Yeah.
And
One thing we thought about, especially again, because we don't have a full-time lawyer, is just picking the top 2 or 3 legal needs that we've seen in our facility and screening for those only as kind of a pilot. And we also divided it into like emergency needs and like sort of urgent or non-urgent needs. So it's funny because what our lawyer will say is a lot of times it's actually not as urgent as you think it is. And a lot of times things can be solved within a 3 to 6 month time period, other than like disability and SSI, which is a lot longer. And sometimes it's just a phone call she makes and the problem is solved. So I think, that was something else we thought about too, of like, here's our emergency, this is our emergency referral system, which includes, I'm going to be evicted in 7 days. I just got notification. It includes protective orders, and it includes one other thing that I'm blanking on. But it's kind of like an emergency protocol, of like, we can help patients with these emergencies, and there's actually a small number of emergencies, but we will take the top 3 things that we have found at our institution and help with those. Or you could focus on a patient population. We've thought about that for funding purposes as well. For example, we have a substance use program where we have substance use counselors who are amazing. So we thought about piloting with them first, and then slowly expanding as we get more money and more buy-in.
So what I was going to say, in our system, we do a lot of screening for substance use, like we all do, and often we're just giving them a list of detox centers that are all full. And so we have it's called a bridge clinic at MGB if you're interested in that. And that's one place where we can house some of these legal services. But effectively, we're doing just what you're saying, is we're screening for a health issue that we just can't meet. And so there's one counter argument.
And I mean, there's a counter argument, which you probably don't want to go there, but philosophically is worth thinking about, right? Which is like, are you liable for not knowing?
Yeah.
Right, which is a whole nother thing. You could explore that. I'm not sure it's going to hold a lot of weight with your legal counsel, right? But I think, I think it is something that probably should be explored more, because I think there's potentially, like, let's say if you saw someone you didn't pick up they were a victim of trafficking, or a victim of domestic violence, and then something like that happens, like probably worse. So.
Spoken like a lawyer.
So thinking of voting as a social determinant of health, have you guys thought of including voter registration as part of your legal services that are provided?
We have not, but it's mostly because I don't think that's within the scope of what our legal aid society does. Not that they would be opposed to it, but we have not thought about that.
I mean, like technically through like the Voter Act, like you can, because it's like a hospital. If you
Yeah.
go, they can.
Yeah, it's like I said, it's not something our legal aid society does, so we try to align it with what they can help with. But certainly, like, I think that's the benefit of a lot of these things, is you can tailor it to what your hospital does, and when you're looking for a legal partner as well, if those are the needs that are important to you and your patients.
So we have, I think both at Harbor we did, and there was like Vote RX a couple of years ago. There have been other efforts in terms of putting it in. So we sort of added it in as part of the suite of services for social determinants, but not necessarily for a lawyer to participate in unless someone's like trying to vote and then they get denied. Then obviously at that point we involve a lawyer. But yeah, I think definitely we've done that. I think we did it at Highland right before I left, and then we definitely did it at Harbor a couple of years ago for the last presidential election. So.
MGB has Vote ER, which is Alistair Markman's program that I think is more national now, but that's one example of a model.
As far as screening tools, do you have something that's validated as far as using a screening tool, and is it integrated into social determinants of health screening questions, or is it kind of something that's more standalone? Because I'm just trying to picture how to put this into kind of what we have now, and is it the addition of a couple of questions that you could look at, or is it kind of something separate? Because what you showed up there was really cool, but it's also overlapping a lot with what we already have. And so I'm just wondering what we have for validated kind of questions to add.
I don't think there's anything validated, but there's a lot out there through the National Center for Medical Legal Partnerships and looking at what other legal teams do. So what we did is we took a lot of those screening tools that exist through the National Center for Medical Legal Partnerships, we made our own, and then we went through it in painstaking detail with our legal team, because like one of them was like, do you have a, it's like a housing question, like do you have a home right now, or are you risk of losing your home? And the legal team was like, we can't help with that. We can help with eviction, we can help with accommodations, we can help with X, Y, Z. So we made sure that every need we asked for was a legal need that would be tied to a legal intervention that they could help with. We had thought a lot about how do you integrate social needs and health harming legal needs as well. It gets a little bit complicated that like, I don't know, maybe I've thoughts about this, but I haven't like really come to a conclusion in my head of like, do you just do two separate or do you do one? Like, do you say, are you in need of shelter? Are you having problems with eviction? Are you having, do you put all housing under one? Do you put all food under one? And how does that work for patients? Like, we want a short screening tool that actually works.
Yeah, so I spent more of my life on this than I care to elaborate on, but for LA County, we developed across health services, DPH and DMH, sort of our own Frankenstein screener, which was based off of all the evidence out there for social needs, and it was this like comprehensive set of questions that included social and legal needs. And then a lot of it was evidence-based, a lot of it was sort of standard of practice, like from Prepare, and then we went through and really put it all together. And then the guidance that was provided was like, you don't need to use this giant thing as a whole. You can take any pieces of it and use it as well. Obviously, from a pure academic standpoint, there's arguments of like, if it's been validated as part of a question set, is it still validated when it's two? But like, I don't know, at the same time, just from a very pragmatic standpoint, it's like, do you have enough food to eat? Like, do I really need to validate that like 8 more times, or like, is that good enough? So like, I think there's sort of that tension. So happy to share that. It's, that, like I said, we spent a couple of years in LA County putting this together, and then I've sort of used that as, now I just sort of take pieces out of it when we need to do social screeners.
And I think too, it's helpful to add what's local to you. So for example, we knew that we'd be seeing a lot of trauma patients, so we added in a question about victims of crime compensation. So we added in a question of like, have you heard, if you were injured, have you heard of this? If so, have you received this? And then our HVIP team works with another organization, Atlanta Victims Assistance. So they actually it's a legal team that then enrolls all of the patients in it. So our lawyer helps with denials if the VOCA funding was denied, but there's actually another team that's kind of in between. So I think it's helpful just to think about your local context too, to say like, maybe this doesn't really matter, or we see a lot of this and this is not included in the legal need, and can our, occupational injuries, for example, like can our lawyer help with that? So yeah, I think that's why it was so painstaking, because they were like, well, in Georgia, this is how this works, and I was like, well, shoot, what are you gonna do about this?
But I think the other thing is you could potentially, depending on what you're screening for, right, already, it may be a question of do you want to add more to your screener versus do you want to sort of train the people who are working on the positives to do other screening offline, right? That's another way to do it as well, if you're specifically trying to target legal needs. So I don't think there's an established right way to do this.
Yeah, we've been really trying to think about, like, with all the social needs screening, how do we integrate health harming legal needs into that? Because that's, again, I think another way to, like, get more information on, like, we have no idea what the true needs are, health harming legal needs are of our ED patients. And so I think that's something to, like, really work with social screeners on, and how to integrate those two together.
Maggie, same as Cal, I think had done a pre-COVID legal needs assessment in our MGB system, and now we're working on doing a post-COVID assessment, and that would just sort of give us the ability to have a targeted screener
your needs assessment something that could be shared or used to look, like we have a very rural system,
Mm-hmm.
health system. I suspect the needs may be a bit different.
Yeah.
Yeah, Andy Beck has some in the pediatric specific population out of Cincinnati, and then like you
There are
published a
several.
study and
Yeah, there are several rural partnerships that have been published on. And there's actually, at least in Atlanta, or at least in Georgia, there's more funding for rural MLPs through the state, than for Atlanta Legal Aid, because they recognize how important that need is. What state are you in?
Vermont. We have a network that goes across upstate New York.
Yeah. Do you know? I don't know, I feel like you know.
Or-
Legal Aid Society in every state.
Roughly, I don't know the ones in Vermont specifically.
Yeah. But yeah, I would actually think rural is like might be a good option for funding, given the unique needs of individuals. Well, thank you all. Appreciate your time and attention. 12 o'clock.